Okay. All right. So, good morning, everyone. I'm Larry Boris, the Executive Director of the National Association of Worksite Health Centers. I want to welcome you again to our series of webinars on key issues impacting on-site, near-site, mobile, and virtual health centers. I'm pleased to have today's program on musculoskeletal care triage, how employers are reducing the burden of musculoskeletal injuries. And our content speakers today are from Proactivity. Let me introduce Ali Hartman, who will introduce our other speaker and the topic of the day shortly. But before we get into that, I did want to mention that I want to remind NAWHC members that we have our first Monday roundtables, the first Monday of every month, which is an informal networking opportunity to just share information and experiences with other members on a topic of shared interest. Last month, I should say, March's topic related to how to select a worksite health center manager. Next month, we're going to go into other topics. So please, these are free programs. We encourage you to participate in them. Take a look on the website, nawhc.org, on the homepage to see what the next topic is for the day. And we encourage you to be part of this because networking is really the key. Also, so you know, early notice if you're not aware, our annual forum this year is going to be August 22nd and 23rd in Indianapolis. So please put that down on your calendar. So with that, let me turn it over to Ali.
Awesome. Thanks, Larry. Well, I am super excited and honored to be on here presenting today with my colleague, Dr. Mark Ciolek. We are going to be covering the topic of musculoskeletal triage. And really, we'll get into the details of it today. We'll share some case studies and hopefully paint a pretty clear picture of what this is and kind of the impact it can have on workforces. But ultimately, as we sort of set the stage, it's really just getting people, particularly in this case, employer populations, access to good information about the aches and pains that they experience as quickly as possible so that they can have some support in making the decision of what they do about those aches and pains, right? I'm sure all of us on this call have experienced our own aches and pains in life. And we know the good news is most of the time, those aches and pains will resolve on their own. And so having someone to be able to evaluate that and tell a person like, hey, we've evaluated this and we think you're going to be okay, can be incredibly powerful to allow the body to do what it does, which is to heal and recover. There are those cases, though, where you have an onset of an ache or a pain, and it doesn't resolve on its own, or it would benefit from more further thorough evaluation or even care, and having a strategy in place to help people to get to the right person that can help give them some decision support as they make that decision can ultimately have a major impact on both the outcome for the individual that's experiencing that pain, but also on the downstream side of costs and getting that person just what they need, only what they need at the right time. So we'll talk a lot today about work-related concerns, but of course, this idea of musculoskeletal triage could really be suitable for both work-related and non-work-related concerns, depending on your setup. So without further ado, we'll get into it. We've got to start with a little background on musculoskeletal disorders, you know, kind of in a more broad context before we can get into the details of musculoskeletal triage. This is not a new problem, right? Those of you that have been around for a while know that musculoskeletal has been sort of a catchword and a common phrase used a lot especially in the employer setting, because it's been a big problem for a long time. As early as the mid to late 90s, you know, we started to take notice of this problem. So in that early mid 90s, late 90s period, it was already accounting for over 3% of the GDP. If we look at kind of global economic impact in the United States specifically. We saw that continue to grow throughout the first decade and mid into the second decade of the 2000s, right? And by 2014, it was accounting for almost 6% of the GDP, musculoskeletal alone. So that was a massive amount. I mean, we're talking trillions of dollars here. The interesting thing about musculoskeletal is that, particularly in the working population, the incremental indirect costs outpace the direct, right? So the only way that that can happen is if it's taking people out of the workforce. If people are no longer able to work because of the ache and pain conditions that they're having. And the reality is, whether we want to talk about costs, which of course, we see the early trend heading in the wrong direction, but it's not just because things were getting more expensive or technology was advancing, so we're doing fancier, more expensive procedures. We look at the actual proportion of people experiencing musculoskeletal conditions. It's followed a pretty linear trend upward in that same time period. There does seem to be kind of a sweet spot where this thing sort of gets out of control, and that is largely between more those early mid-working years and then switch over into the late working years. That's where we see this dramatic shift in prevalence and distribution of cases for musculoskeletal. So that was sort of some of the beginning of the story, and for people like us and my biased view, so some pretty smart folks in our organization long before I was around started to say something's not right here. We know a lot about the musculoskeletal system, and in some ways, if something's following a pattern or a trend over time, then certainly we can predict some things, and if we can predict things, maybe we should be able to prevent them in some sense. So they got to work on that. And we'll get into that in just a second. But the reality is that this trend has continued since then, right? That data is at this point a decade old, but the story really hasn't changed that much, despite a lot of advancements in health and medicine. The musculoskeletal story is still looking kind of grim, right? If we look into 2017, we see much of the same. Musculoskeletal is towards the top of the list when we look at years lived with disability. And we get into as recent as 2020, again, much of the same. Those musculoskeletal disorders or things like opioid use disorders, which certainly have their link to musculoskeletal disorders, amongst other things, the story is still the same. It's a huge problem, and it's certainly impacting people in their working years. So for us, we said there's got to be a better way, right? This problem is sort of out of control. And like I said, if we can sort of follow a trend and start to predict how things are going to go, then certainly we should be able to, in some way, prevent things from continuing on this path. And so that is sort of the birth of our adaptation of a prevention model, right? Our prevention services model looks at the normal distribution of a population. So that's that curve there, knowing that any population may be shifted one way or the other, depending on their baseline health. And at the bottom is your typical progression, right? From influences and behaviors for an individual all the way down to those things dictating ultimately events and ultimately costs. And we know that individuals, as they kind of pass through their life's journey, they may move forward and back on this spectrum. And if we take sort of our 4 levels of prevention and layer them over top, this pathway, this progression, and a normal population distribution like we would see in a workplace, we, of course, at the foundation have primordial prevention. That's keeping healthy people healthy, a culture of health, if you will, within the organization. And we layer our other 3 levels of prevention on top of that, right? Primary is really those healthy people. We want to keep them on the right side of health, right? Help them grow health assets and stay as far away from risk of illness and injury and disease as they possibly can for as long as we possibly can. Secondary prevention is where the bulk of most of our population lives, right? In this stage of we're trying to identify, there's some risks on board. There's maybe some signs or symptoms that those people are starting to develop. But for the most part, they're no more than smoldering, right? Or smoke. And so secondary prevention tactics, we want to be able to identify that smoke and hopefully help to pull those people further and further away from catching on fire, if you will. And then tertiary prevention is the part of the prevention model that deals with the fire once it's sort of taken flame, right? Went into flames. How do we effectively and efficiently manage those fires? But minimize costs on the downstream side as well. Of course, the goal in any prevention model is we want to get as many people in that population towards the left side of the screen as possible and push as many people as we can away from that tertiary side of the spectrum. And certainly that is an important effort and definitely something that we're trying to do. But the reality is today, when we talk about musculoskeletal triage, we're really zoning in on this tertiary end of the spectrum, right? The people that are experiencing some onset of ache, pain, injury, within the workforce. We know that it's a relatively small amount of people when we think about that population curve distribution. It's really a small tail end that ends up getting to this tertiary prevention side of the bucket that actually has something that's like, no, this is considered to be more than just smoke. This is on fire. This is an active problem. But the reality is we know that even though it's a relatively small number, when we consider the total population that we're looking at, we know that it's incredibly costly and incredibly burdensome for the individual, right? For example, if we look at kind of the typical distribution of health spending within a group, we know that the top 5% of spenders account for more than 50% of the total spending. So it's really important for us to think about ways to manage this portion of the curve, right? The people that end up here, how do we make sure that we're managing them as effectively and efficiently as possible? So tertiary prevention overall is really this idea of best possible episode management, right? In the musculoskeletal realm, a lot of the work and research has been done in timing to conservative care provider. So Starbucks was really the first people to do this and put it through some pretty rigorous testing. They were getting absolutely crushed by low back pain. And so they went to their Virginia Mason and they said, listen, we're getting crushed by this. We need you to fix this problem. Like, this is costing us so much money. So fix it. And so what they did was they applied sort of this idea of lean pathways, right? And they said, okay, let's try routing an individual that has low back pain, it's non-emergent, to get to a conservative care provider and a physician as quickly as possible, rather than going more that traditional route where they sort of end up going through a lot of diagnostics and some imaging, and then ultimately end up at that conservative care provider. What they saw was that there was tremendous savings, about 50% savings. And they weren't the only group to do this. Intel then went in and did it again in a slightly different way, but reducing that time to conservative care. And ultimately, they found that time to get a person from out of work back to work was also about half. And then if we want to talk a little bit more big data, Optum looked at this in a more zoomed out way, and they found very similar, that it really seems to be that timing to a conservative care provider in something like low back pain that has a major impact, certainly has a major impact on total costs. So that's tertiary prevention overall, but a lot of that is about care, right? It's about getting the person to a provider that can deliver good quality evidence-based care for the right conditions. What we're really talking about today, when we talk about triage, is a little bit before that, right? It's the exact sort of onset and determining, does this person actually need care? If so, what kind? Or do they need something else? So that is really where triage lives. It lives right at this line between maybe something is smoking or smoldering and crosses over the line into an active event or injury or incident. So I'm going to turn it over to Mark to talk a little bit more about the history of triage and some of the specifics of what this type of a service looks like in a prevention solution.
Great. Thanks, Allie. Yeah, so triage as a concept isn't a new idea. And so this is actually something I just learned, is that the actual process of triage dates back to the Napoleon times. Is kind of when they think it actually started, and these if they were doctors, I think, rode around on these carts that they called flying ambulances, kind of picking people off the battlefield and bringing them to whatever care that they needed. And the actual word triage itself means basically to split apart into three. And so that idea is a pretty good one to start with. And although there's different ways you can think about triage, to us, it's kind of maybe the simple place to start is this idea of a almost traffic light for, which route are you going? So if you go next, Allie, maybe 2 clicks here. So if you think about, again, that green, yellow, red light, if we see or talk to an employee and make some type of evaluation, green light would be, that person's good to go. No signs of harm, no limitation. Educate that person on what they should expect. Is there some follow-up? Maybe we check in with them, but otherwise, keep rolling, like it all looks good. No big signs of harm. If we go next, that yellow light situation is that person's evaluated. There is some limitation, but really no clear signs of distinct harm. It's not quite sure at this point where, what exactly is going on from a musculoskeletal perspective. in that situation, typically we're giving that person some type of informed first aid. So not just general, like we hand them a pamphlet, but some type of informed first aid related to what they have going on, whether it's some type of sprain or strain type situation, or it's something else. Really setting the expectations of, again, where do we think this will go? What is the timeline of an inflammatory pathway, and what should you expect tomorrow morning? Because it's probably going to be different than how you feel now. And giving that some person some type of observation period where that person's followed closely and make sure everything heads and kind of stays either on that yellow line or drops back down into the green zone. Then a red light position, that would be, okay, we talked to this person and there's actual clear red flags on board. We need to accelerate this person in some more type of medical evaluation, or there's clear signs of harm from a musculoskeletal perspective that, again, requires more evaluation, and timeliness is probably part of that situation. So, we should route them appropriately. So as like a high level, like, there's definitely a lot of nuance to this process, but if we just start at this and say, can we do this process really well, and route people in these general categories, in our experience, that gets us kind of a lot of the way there to making a big difference on a problem like this. We can go next. So really, what are we doing? Number one, it's the idea of, can we keep people out of the emergency room who don't need to be there? I don't need to tell all you that a lot of people end up in emergency rooms who probably shouldn't be for simple musculoskeletal injuries. And what we've begun to learn is that, there is some harm of people getting into those situations if they don't need to be there, for simple things like, a strained low back, right? And on the other side of it, there's the idea that, people who should or do need help, we should get them almost like the fast pass, like if Disney World fast pass to the short line, to the provider that they need to see, rather than taking the 4-hour route to the conservative care provider they need, or physician they need, or imaging they need. So really, it's the idea of get the person to the thing they need as quick as possible. It's not a new idea, but it's one that kind of we don't see kind of carried out super well in most situations for employers. In the middle kind of sits all the messy middle, basically, is kind of everybody who kind of falls in between that. And in our experience, a lot of this ends up getting left to what's the person's preference, who's their supervisor, what's the employer, what's the relationship between those two people, and really the decisions that are made are not based on sound medical advice, but or evaluation or information, but more just what is convenient, what's that person's preference, and that situation doesn't always get them there, because oftentimes that person's preference may be, I don't trust the medical system, and so I'm just gonna, I'm not even gonna say anything about this because I don't want to be routed into that situation. And oftentimes we see people kind of being left on board who should be evaluated. So the goal is, as always, is to kind of have wins all over, right? The fond after quadruple aim. So from a patient experience perspective, the goal is getting that person the help they need as quick as possible. It's not necessarily keeping them away from care, but getting them to the care they need quicker if they do need it, and keeping them out of the system if they don't need it. So in reference to kind of the data that Ali was going over, we believe that follows that trajectory of getting people to the thing they need faster tends to get them better outcomes, and set them on the right path quicker, rather than doing the merry-go-round into different providers and different types of care. We assume, again, there's lower costs that come along with, because we're missing out on a lot of the unnecessary things, like MRIs for people who don't necessarily need them, or again, routed to different providers. And truthfully, from the provider end, there's a whole lot of experience that we found for ourselves and our providers, that speaking to these people in earlier situations totally changes the trajectory of that person's care. And when you're involved in an employer workspace, you feel maybe some responsibility for, hey, how does this group do in terms of what care they get? And so having that first conversation changes the trajectory of that stuff quite often. So triage nuts and bolts, who does it? What populations are a good fit? Tips for success. So if you go next slide, our background, both Allie and I, is in physical therapy. So, when I started out, a lot of my training was in orthopedics, and how do we get laser focused on this idea of orthopedic conditions and rehabbing them and evaluating them really thoroughly. But in our experience, that gets you part of the way. So, what provider would be good at it? Number one, some type of medical background is helpful. Some type of musculoskeletal background also is a big key in some of this, although it can be done without, if you get extra training. Some type of musculoskeletal background in evaluation of some degree is pretty darn helpful in this. But what we've seen, and Allie, you can click through next to, what we've seen is that, staying on just the clinic side, so people are only lived in the medical care side of the situation. Even physical therapists often kind of get stuck on that side of it, where in our experience, getting into the spaces where employers live and work, that tends to make a big difference with both the trust factor with these employees when having first conversations related to some type of situation that there's a lot of fear that surrounds it. Trust is a huge issue. So although it's not absolutely a requirement, in situations in which we've been able to get experience on the ground with employers and begin to get to know them a little more, get to know what type of work they do, whether it's manufacturing, utility work, construction, that seems to help this process quite a bit in terms of both knowing what the employee is going through and having that trust piece on board. So that does relate to kind of what populations we see as a good fit for this stuff. Number one is they should have an injury problem, whether they know it or not. Having an injury problem, and specifically one that involves distinct incidents happening. So rather than, I've had carpal tunnel that is going on for, it's kind of gradually been onsetting for a long time. Something that's more like, I was trying to lift up this big, sandbag today, and I felt a hit in my back, and hey, I think I need to see somebody. Those kind of distinct incidents that require this decision-making question, people who have more of those tend to be the companies that will fit well into this. So things like manufacturing, construction work, different utilities, people who are doing type of deliveries where a lot of it is not as engineerable. There's a lot of variability in it. And what we see is that they run into these situations in which there's not much that's controllable, and they're having incidents that happen.
Very good. So as we transition into a few more of the details, what should you look for? Let's say you're considering adding this. If you're an on-site or near-site operational clinic and you're looking at how would we add this, or you're an employer looking to bring in some sort of musculoskeletal triage. In our experience, what are the things you want to be looking for? Of course, you need providers, as Mark said, that are suitable, that it's within their scope to evaluate musculoskeletal concerns. So there's many types of providers that are successfully doing this. Like Mark and I said, our background is physical therapists, but there are plenty of provider types that are doing this quite successfully. It doesn't necessarily have to be one particular provider type, just making sure that it's within their scope to obviously evaluate the musculoskeletal system. And then experience, right? Particularly when we're talking about our cases that you'll see are work-related incidents. It's really important that the provider or the service that you're looking into has experience operating in that space, right? You would not, I often say, like, you would never play a sport at a professional level that you don't know all the rules. And there are a lot of rules when it comes to work-related injuries through OSHA. So need to make sure that your provider is really comfortable working in those rules. For example, as physical therapists that work in this space, we learn nothing about that in school. So those are all things that you learn in addition, at least for a provider like a physical therapist, kind of in addition to your training. So just really being clear on that, because you want to understand how those rules come into play. And of course, that musculoskeletal specific evaluation piece. You want to understand the service specifics. Musculoskeletal triage can look a lot of different ways. It would be interesting in our question and answer session to hear if anyone is already implementing this type of service, and if you have sort of like, oh, this is what we've seen, or this is what works for us. But it can look a lot of different ways, right? It could be a phone line that someone calls and they're going to have a phone call. It could be have a virtual service component where there's a kiosk and they're going to use it, or they're going to join from their personal cell phone, or an in-person service level. You need to understand kind of what exactly is the service going to look like? How is it going to work for our employees or our team? And then kind of second part of that is, does that work for our people, right? What will be the ease of implementation and integration? Will it fit your workforce? So for example, a virtual option where people are going to be expected to join through a virtual link, if not a good portion of the population has a smartphone or has a general distrust with technology, is probably not going to be effective. You could spend all the money in the world on a great service with great providers, really fancy, but if it doesn't fit the needs of your workforce, or it's going to be a nightmare to integrate, it's not going to be a good option and give you the results that you want. As Mark sort of has mentioned, there is some benefit to an embedded model versus just sort of like a faceless organization, and particularly with really any medical concern, but an ache or a pain, especially when it is sort of sudden, can be really scary for folks. So being able to talk to someone that there's at least some level of trust with can make a huge difference in the trajectory of that outcome. I think that's why it's a great thing to consider if you already have some sort of either on-site or near-site center that has a level of trust with the population. That creates a really nice foundation to be able to build from. Of course, you want to know about their outcomes, right? So we're going to get into case studies here in just another slide or two. You should be asking any provider that you might be looking at to share their outcomes. They should have data on kind of like, what does a case look like and what kind of outcomes can we expect from this service? And then communication strategies, really important, both with the individual employee, like, hey, what's the follow-up going to be like once they get, kind of recommendations from you? How are you going to follow up with that individual? And again, if it's related to work-related conditions, also the communication strategies that will be deployed with the employer and the employer stakeholders like safety. So what about what we can do with what we already have? Let's say you already are an operational on-site or near-site health center. Maybe you're a small center, so you've got a pretty small kind of tight-knit staff. What could be done with that setup? What could be done with something that you already have? Of course, a prerequisite is having a distinguished occupational medicine process, that kind of understanding that line in the sand. So that comes, sort of first and is a prerequisite. Of course, we won't get into that today, but tons out there to help with that process. But that is a prerequisite to being able to implement a musculoskeletal triage service within your existing operation. Having a systematic process for access for those work-related needs is essentially the first step, right? How are people going to get in touch with us, and who on our team is going to be able to field that need, or what individuals on our team is best served to field those needs? It requires creating that communication system with the employer safety professionals and the employees, right? How are people going to get in touch with you to get the input? And then a really important factor is those frequent feedback loops with, again, both the employee and, in those cases of a work-related condition, the employer safety professional or stakeholder group. It's important to consider all options for management. So when we talk about musculoskeletal, again, I think the initial thing is thinking that it's like getting people to musculoskeletal care faster. Not necessarily, right? That's not necessarily the case. There's a lot that can be done for an individual, that is before getting to the point that they need care, right? Sure, it's important to be able to refer out and escalate a case when it needs to, but there's a lot that can be done in terms of self-care guidance, first aid, using that observation period like Mark talked about. And then, of course, considering developing a relationship with a trusted musculoskeletal expert if additional support is needed. If you're kind of like, yeah, this is not our jam, and we don't really have anybody on our team that this is their jam, looking at, okay, how could we develop a relationship with the musculoskeletal expert to enhance the services that we're offering at our on-site or near-site center and kind of expand our scope a little bit. So with that, we will go ahead and transition into our case studies. We'll start with some individual case studies that Mark will take you to, and then we'll look at an employer population.
Perfect. So yeah, we wanted to give you guys a little bit of a view of like, all right, how does this stuff go? If you're talking about a triage, we call it triage call. So that's typically how these come in. So this is an example from a gas utility. So this employee was a gas construction worker. He experienced pretty significant back and related leg pain immediately after lifting a manhole cover. So basically 100 to 150 pound metal cover, they place some hooks on it, they pull it up from the floor. So on day 0, basically 2 hours post incident, the employee called the triage hotline to seek basically self-care advice. And so what happened at that point is it was determined that it wasn't an emergency at that time. There definitely was some things the person was experiencing. There were no clear red flags, but enough that the employee was, probably should be kind of entered into this triage process. And so kind of in that yellow light zone. And so it was kind of given self-care advice for that, kind of set some expectations and cleared the initial red flag screen. And then day 1, this person was reassessed in person. Again, further testing was done, kind of confirmed in person that wasn't able to do over telehealth, and kind of continued to show good signs of no red flags on board, but things that kind of basically needed monitoring. So kind of entered into this monitoring period with self-care along with it. Reassessment on day 5, again, that was in person. So continued guided self-care through that period. And so, typically these will be anything from, general mobility recommendations, things like heater ice, things like over-the-counter NSAIDs, and any other kind of work habit change that would tend to fit into this person's both work responsibilities, but also help to keep things from being re-irritated. Accelerate to day 19. This employers kind of continue to follow over that time. So kind of frequent communication over that time. Return to pavement braking, which is one of the more challenging tasks for this employee with a jackhammer. On day 21, continuing to progress in his work, but had some soreness, so kind of hit a hiccup, right? So if you imagine, okay, the person returned on day 19, and if you just kind of close the case there, okay, on day 21, we're having some new soreness. So again, another kind of almost reevaluation to, assume, yep, this person's not progressing anymore. So continuing to do that kind of self-care and making recommendations for continuing to work in a way that doesn't cause discomfort for the employee. On day 35, had some mild stiffness, but able to do normal daily stretches that his group does, able to go through his normal work. Essentially, at this point, having normal discomfort that he would feel on a day-to-day, and kind of wasn't related anymore to that condition. So kind of progressed on out towards normal preventative care. Okay, next. And feel free to jump in if anybody has questions on these ones. I know we're getting along into the details a little bit on this stuff. So this next one was a little bit different as a step-down incident. So electric utility employee stepping down from a vehicle into an area which included a curb. When stepping down, they rolled their ankle in the lateral direction, felt a sudden discomfort in their ankle. They're initially not able to bear weight, but then once they returned to their workplace, they were able to apply some ice, things relieved a little bit, and able to put pressure on it. Okay, so enter into triage call, and Al, you can click through all these. So called the hotline, basically 4 hours post-incident. Again, evaluation over the phone, given first aid instruction, things like an ankle sprain will take through typical kind of screening questions and evaluation via telehealth. And that employee was determined that they didn't need x-rays at that point, weren't showing signs of distinct harm right then, but an evaluation is scheduled in person with that person on day 1. So on day 1, there was a reassessment in person. Again, no big red flags on board, so kind of put into that monitoring category and given self-care advice. So follow-up happened through days 2 through 4, continued progression, not showing any big red flags popping up. Continued reassessment on site on day 6, and continued guidance. And by day 11, that person was in the field doing their normal duties, kind of no limitations that they had, and kind of minimal discomfort. And so that case is closed out and moved on. So this is kind of just gives you a general picture of like what can be kind of the cadence of some of this stuff. And if you imagine, if we cut it off at any point before here, there might have been things that were missed, or places that this stuff can kind of go awry. But gives you a good kind of feeling of where this stuff would progress from. All right, I'll kick it back to Allie. She's going to take you through more of a population level case.
Awesome. Thanks, Mark. Okay, so moving on to more of our kind of population level use case. This was a field-based workforce services, fortunately or unfortunately, were initiated at the start of 2020. Their employee population was roughly 1,200 to 1,500 employees. Essentially, what was implemented was a musculoskeletal first call reporting policy, right? Essentially, what we've been talking about today, this musculoskeletal triage, where when there was anything related to a musculoskeletal ache or pain, they would utilize the triage service. Really, the emphasis for us was on decision support, right? We're helping to, just as Mark described in those cases, to evaluate the person's current condition and help provide support in making decisions on how to manage this moving forward. And so in full transparency, this was not designed to just be a musculoskeletal triage rollout for this client. We had full intentions of rolling out our full-scale prevention model with them. The pandemic had different ideas, right? All of a sudden, a big wrench was thrown into the plan. So we ended up rolling out pretty much primarily in 2020 and up until a portion of the way through 2021. Largely just our musculoskeletal triage service. And you can see, even with just kind of that isolated component of what we normally roll out, our full-scale system, it had a really massive impact on their costs as it relates to musculoskeletal from their workers' comp side. So their average spend in the years leading up to 2020 was 1.2 million, and 2020 and after, their average was 180,000. Like I said, around that mid-2021 mark, we started to roll out some of our other levels of prevention, and you see that problem continue to get better. So it's not to say that like musculoskeletal prevention is all about just managing these episodes, right? That's still on the reactive end of the spectrum, but even that can have a massive impact. So this is kind of a view of what it can look like in a population. So as we get closer to our open discussion and our question and answer, really what we see is opportunities, right? We know that musculoskeletal is a huge burden on organizations, right? It's very often in the top 3 in terms of overall healthcare costs, a kind of piece of the pie, if you will. Musculoskeletal often makes top 3 on the list. A small number of people really are yielding a large amount of the cost and thus the burden. And it's been well documented at this point that early contact with the right professional can significantly impact the trajectory of an individual's case moving forward. It's not just about faster medical care, right? There is a lot of value in putting a qualified professional in the position to be able to help that person as soon as possible when they have an onset of musculoskeletal symptoms. It's really, I think, as Mark alluded to, but to put it directly, when our skill set is most valuable, right? It's a lot harder to get someone to recover from back pain that has had it for 5 or 10 years and has kind of been through a lot as it relates to that ache or pain. But man, when we see that back strain on day 0, I'm a lot more confident in our trajectory to get that person better. And a lot of that has to do with just being able to be there and help them know that they're going to be okay, and help them to know how they can maximize that opportunity. It really is a simple model, but it's quite complex and nuanced in the details, right? There's a lot to this. And our team has spent a really long time, I think, getting well-versed in those complex and nuanced details. But at the root of it, like Mark said, it really is kind of something that has been around for a long time, this idea of triage, and can be relatively simple, at least high level. And as we've alluded to multiple times, we're big believers that systems beat services every time, right? So while we've talked a lot about a triage service today, ultimately what we believe is sort of the best thing to talk about in the musculoskeletal space is injury prevention systems. And services may be a component of that, but certainly not the end all be all. So we will now open up the floor for questions. I'm not sure if people are able to mic up or just type into the chat, but we'll open up the floor for questions or comments.
Yeah, great. Thank you very much, Mark and Allie. So the way we'll work is I will ask people to unmute. I'll call your names based on how you show up on my screen. And then please ask whatever questions or comments or share any experiences or information you might have. So Beth, let's start with you. Beth Mayat. Unmute.
Hi. Let's see. I don't really have any questions. I function in the same space as well. I'm the owner of ErgoWorks here in Minnesota, and we provide injury prevention services as well as job analysis and ergonomics to companies. So this is our bucket 100% of the time. So great presentation. I loved all your information and a lot of your data. So it's just nice to hear how other people talk about it and kind of what those talking points are to employers as far as the benefits for their employee population. So thank you.
Great, thank you. Carly B, unmute please and give us your thoughts and questions. Carly? Okay. Jacques Stott, Jacques, you want to give your comments or questions? No? Okay. Let's go to Jeff Kessler. Jeff, any comments or questions?
No, I don't really have any questions. I thought it was really helpful to see the evaluation of the population. That's always interesting, and then a great process that you guys have. So appreciate that. We're in the allergy space, so a little bit different, but still evaluating people and figuring out what the impact would be in helping them. So thank you for the fine presentation.
Thank you.
Cool.
Mike Fitch, Mike, and comments or questions? Please? Take yourself off mute, Mike. Okay. Nicole Miller, Nicole, comments or questions? Nicole? Okay. All right, so well, let me ask you, Allie and Mark, a number of employers are going to really an integrated physical health approach, having not just physical therapists, but also chiropractors, acupuncturists, massage therapists. Can you talk about if you've done that or if you've got some experience in it, how the providers can best work together?
Yeah, great question. So we have several groups that we are certainly not the only service that is provided, particularly on the conservative care end. So one of the clients that we work with also has an on-site chiropractor. And it's great. I think the opportunity for people to see providers that have a little bit different lens, but are all seeing particularly these musculoskeletal problems through, hey, how can we help the body to help itself? Versus necessarily immediately jumping into something more invasive that as we get more research, we're just realizing may not be necessary all the time and certainly doesn't come without risks. It can be really conducive. I think having good communication between the providers is key, working as a team as much as possible, even if you're sort of separate entities, but being able to work together and be complementary, because ultimately you just want to create a space where people believe that they can get better. And I think all the providers that you mentioned and many more do that really well when they're all working on the same team. I think you want to make sure that the providers are not seeing any there's no need to be territorial, right? Because we're all kind of bring something valuable to the table. So that would be my major recommendation, is seeing it as, hey, this is our conservative care team, if you have multiple different providers, versus there being any sense of competition or a sense of territory.
Yeah, we have some models where the patient can decide essentially which provider they want to see first, or sometimes they'll see the nurse practitioner or physician who refer them to one of the team members. And oftentimes the team then will discuss between their different backgrounds who might be best served or who should get involved in an activity, so that it is more of an integrated team approach rather than, as you say, individual practitioners, because you want to take advantage of that as well. It also is beneficial if you have a lot of people leaving the work site to see individual practitioners who are like chiropractors and acupuncturists, massage therapists, to bring those services on site or near site, at least periodically during the week, so that people do have access, and you can link it very closely in with your on-site and near site services.
Mhm.
All opportunities. All right,
Yeah,
well, if there's no, please go ahead.
I would just add, in those situations, I think it is still important to point out in a triage role, like it almost probably ends up sitting as a different, or like a subspecialty, like there's a person responsible for that. Because the challenge with the patient choice or things like that is they may be routed in the wrong way, or ensuring that the provider is kind of well versed in the OC health side of things and not providing treatment for things that don't require treatment, because that kind of pushes them over into the recordable injury realm.
Right, exactly. And that's why, getting together as team meetings or team circles on MSK would be is a good idea. Of course, the other issue that employers have, very pragmatic ones, do you have space for all these people and all their different types of equipment and tables and stuff? And the more that you can share and plan on that ahead of time, the better it is. Also, our experience is that when employers offer these kinds of services, they fill up pretty rapidly. And oftentimes it is hard to get an appointment. So employers sometimes will expand the number of hours or days that people take advantage of. Well, any final comments or lessons learned, Allie and Mark, that you want to share before we close?
No, I don't think so. If anyone has any final questions, feel free to send them to myself or Mark afterwards. We're happy to kind of field any other questions, but otherwise, thanks for being with us, and thanks, Larry, for giving us the opportunity.
You're welcome. Thank you all very much. I hope to see you at our next program. Everybody have a good week. Take care. Stay warm.
Thanks,
Bye-bye.
everyone.